features, but it comes late. So it comes in the second week, the periungual disformation. And this is pathognomic of Kawasaki disease, the BCG reactivation. This is almost not found in almost any other disease. So if you have a child presenting with fever and a BCG reactivation, the diagnosis is almost Kawasaki unless proved otherwise. This is something that we had described some years back, orange-brown coloration of the nails. So orange-brown chromonychia, and now this has been almost been validated across countries. So it's a different ethnicities also you can see. So why identify Kawasaki? Even when Dr. Kawasaki described his findings, he did not know that these findings were associated with involvement of coronaries. So it is the most important cause of acquired heart disease. Untreated, almost 20 to 25% of incidence of coronary artery aneurysms. It remains the commonest cause of myocardial infarction in children. And this is what happens if you don't miss a Kawasaki. So by definition, it's a self-limited vasculitis. Even if you don't treat, the fever can go down after 2 weeks, but it leaves behind this multiple aneurysms you can see over here. This is one of my favorite pictures with Dr. Kawasaki, and that's Professor Kato. Let's go to the world of arthritis. Juvenile idiopathic arthritis, which is the commonest cause of chronic arthritis in the pediatric age group. So look at the classification criteria. This is less than 16 years, but presently this was an old classification criteria, the Eiler classification criteria, and there has been a recent one proposed by the Pediatric Rheumatology International Trials Organization, that is PRINTO. They have proposed it less than 18 years, and they have, the categories have changed. So one of the commonest form of arthritis is a reactive arthritis. So an infection, and then you get an arthritis, maybe a GI infection, and then the child comes with a very, very severe pain in the joints, high inflammatory markers. So that's a reactive arthritis, and there's something again known as the, not a rheumatic fever, but the post-streptococcal reactive arthritis to complicate the situation further. The affection of the eyes and the joints. So a painful red eye may be an association with reactive arthritis. We all know the Ritter's disease, but this is always attracts attention, a painful red eye. But what about the chronic uveitis, which goes unnoticed in patients of GIA, especially the one with the young children with ANA positivity? And that is the importance of doing routine eye checkups. The slit lamp examination should be done routinely, or otherwise you can come up with complicated cataracts also, like this child. So management of GIA has moved forward. From the 1990s, methotrexate was used, and subsequently if you look at the pathogenesis, evolving treatment, now we have a whole lot of biologics being used in GIA, and now it's treat to target. One should not forget the arthritis mimics, especially leukemia. Acute lymphoblastic leukemia in children can present just with arthritis, and sometimes it's very difficult to pick up. So if you have a child presenting with pain in the night, tenderness over the joints, always remember leukemia. There are other malignancies as well, like a neuroblastoma can also present with arthritis, and there's the Langerhans cell cystocytosis, which can also present with arthritis, and this is the classic osteolytic lesions in the skull. Child presenting with deformities in the joint, normal inflammatory markers, a very symmetric look. This is a skeletal dysplasia, not a GIA. One of the most important things is lupus. So the prototype of all autoimmune diseases and presenting sometimes with any manifestation under the sun. So one must remember that 15 to 20% of lupus, it commences in children. So there are lots of classification criteria, and this is the present 2019 ACR EULAR. And pediatric lupus can be very severe at onset. They usually have a very aggressive clinical course compared to the adult population. I won't go into the autoantibodies. So we have all seen these slides, alopecia. This is one thing which is very pathognomic again, the painless palatal ulcer. This is a child with toxic epidermal necrolysis, the vasculitic rash, the cardiac affection, the CNS affection. There's a huge bleed over here. The lupus with a triple positive antiphospholipid antibodies. And this is one of the most dangerous things ever encountered, a diffuse alveolar hemorrhage. Sometimes it's very, very difficult to resuscitate these children. Lupus nephritis, the most serious long-term complication, and almost 75 to 80% of children will develop some degree of nephritis over the years. So we all know that pediatric rheumatology is all about pattern recognition. It's the clinician's domain, supported by lab findings. So it's very important to keep an open mind and look at the pattern of the disease. Hinox-Schönlein purpura, the classic rash. The classic triad is rash, arthritis, and pain abdomen. One must remember that sometimes the rashes may be delayed and they can just present with pain abdomen. So spectrum of vasculitis is broad, from some rashes to fulminating disease like this patient of polyarthritis nodosa who had lost some of the digits. I won't go into the classification criteria, I think, and this, you can have Takayasu, the so-called pulseless disease, but one should know to intervene before the pulses go off. And small vessel vasculitis, these are some of the pictures I think you have seen, Behçet's, and this child had presented with symmetric proximal muscle weakness, juvenile dermatomyositis. Now, this is, I will call a commandment. Thou should not forget infections, because a lot of these children, because they're immunosuppressed, they will get some unusual infections, nocardia, fungal infections. So one should not forget infections while dealing with these diseases. And then we have the fascinating world of the primary immunodeficiency disorders. I think we have a master over here, Dr. Biman, sitting in front, who is fascinated with this disease. And now you can see you have more than 400 genetic defects. And primary immunodeficiencies now are known as inborn errors of immunity, the IEIs, because autoimmunity goes almost hand in hand with the primary immunodeficiency disorder. It's just not infections, serious infections, unusual infections. It's also a lot of autoimmunity. And finally, the world of inflammation, autoinflammation of the cytokine storm. You can see that 5 million ICU admissions per year. This is from US, from a presentation in the US. 4 million almost they experience cytokine storms. So this was the cytokine storms and the HLH. Sometimes in the late 70s, I think people started thinking about these disorders, hemophagocytosis, but we again now know that hemophagocytosis is not equivalent to HLH, because you can have HLH without a hemophagocytic demonstration in the barrel. So these were the criteria. So we know that it's a potentially life-threatening condition, by no means rare, characterized by activation and non-malignant proliferation of the lymphocytes, leading to this, what you know as the cytokine storm. So the revised diagnostic criteria, HLH treatment was always considered quite difficult with etoposide and cyclosporine and steroid. But what we encountered in the tropical countries is mainly an infection-associated HLH. Those were the treatments for the genetic HLH. So we had published this, the infection-associated HLH, just being treated with few doses of dexamethasone. And then you can have macrophage activation, which is almost synonymous with HLH. And this is a very life-threatening condition in pediatric rheumatology. One must remember to pick up MAS, otherwise these patients can have a devastating consequence. This was the 2016 classification criteria for MAS in SGIA. This was our own experience with MAS, 10 years experience. So cytokine storms, I think, and you can see that it is a unifying thing. So infection, virus, SARS-CoV. So a lot of things can, and this was this COVID area, the times they were changing, we encountered a new disease entity, which was known as the multisystem inflammatory syndrome, the MISC. So this was the children presenting with fever, rashes, diarrhea, and suddenly they were going into shock because of a very fulminant myocarditis. So we had a lot of experience over the 2 years treating these children. And just last 2 or 3 slides. So there's nothing quite as powerful as a worldwide pandemic to bring increased attention to a cytokine storm syndrome. So CSS has garnered attention from a vast variety of biochemical disciples, and the final thoughts that does viral hemorrhagic fever represent hemophagocytic syndrome? We have encountered adenovirus-associated CSS. We had an adenovirus-associated epidemic almost in pediatrics last year. And monsoon is here, can dengue be far behind? So HLH and dengue, that's a known entity, but the final thought that is severe dengue really a cytokine storm syndrome, and should we think of immunomodulators for dealing with the storm? Fever definitely is not a sign of antibiotic deficiency. So we should, whenever we're addressing a fever, we should keep our eyes open and think. So thank you. This is our team from Institute of Child Health, and those are my fellows over there. So we have started a fellowship program in pediatric rheumatology over the last 2 years. Thank you.
Excellent talk by Dr. Priyankar Par. I am really mesmerized by his talk. Thank you so much. It was a wonderful experience, a learning experience for all of us. Any questions from the audience, please?
Just a very small question, not a question really. Would celiac disease, you would like to speak a little bit, if it's included in this?
Celiac, ma'am?
Celiac disease.
Celiac disease.
Yes.
Yeah, celiac disease is definitely, they will present with a variety of manifestations, definitely. Failure to thrive, abdominal distension, chronic diarrhea. And as once thought of that celiac is not much present in India, that's, I think, quite a misconception.
Yes.
Celiac is very much prevalent. In fact, we are now coming up with a lot of patients with early onset inflammatory bowel disease. A lot of patients, they can have, again, varieties of manifestations. Sometimes they present with arthritis only. So IBD presenting with arthritis, that's sometimes difficult to diagnose initially because the arthritis dominates the clinical picture.
Thank you.
Thank you, Dr. Pal, for an excellent session. I request Dr. Palash Mondol to please felicitate, sir.
There is one more question.
Hello. Good morning, sir. I have a question as a pathologist to a pediatrician, as a rheumatologist. Have you have any preference to a dilution that for the ANA, anti-smooth muscle antibody, LKM, and NCA? Like we have a dilution protocol for the adult, as per I know. And like in pediatric population, do you have any preference of lower dilution or the same dilution as we have like in adult?
I'm not aware of any other because I think it's the same.
Okay.
Now, for entry point for a SLE diagnosis, it's 1:80, I think, according to the last classification criteria.
Okay. And it is the same for the pediatric and adult both?
I think so, ma'am, because I'm not aware of any other
Okay. Thank you, sir.
dilution.
Thank you.
Sir, please felicitate Dr. Pal. A big round of applause, please. Ma'am. I now request Dr. Utso Roy to please grace the stage and give us his talk on automation in hematology.
Good morning. Good morning to all delegates and my respects to my respected seniors. So it will be a short talk on automation in hematology. As you all know, it all started from the discovery of microscope by Dr. Anton von Leeuwenhoek in 1666, and till the time of Wallace Coulter, an electrical engineer who developed and applied the Coulter principle, that is the principle of electrical impedance, which was mostly used in the automated analyzers. So from the time of manual methods like hemoglobinometer and counting in the Neber's chamber under microscope, we have moved to 3-part analyzer to 5-part and now 7-part analyzers in many setups. Coming to the advantages and principles, so the advantages are high level of precision, the flagging of aberrant results, objectivity, that is, there is no inter-observer variability, no slide distribution errors, and many parameters are not available also for manual methods like RDW. The commonest principles are Coulter principle, that is the electrical impedance, and also the fluorescence flow cytometry, that is based mainly on optical scatter and fluorescence dyes. Also there is radio frequency. So the Coulter principle or the electrical impedance is a method based on the measurement of changes in electrical impedance produced by a particle passing through an aperture. Flow cytometry, as you all know, there is a excitation laser and the fluid sample from the cells are coming through, and there is a scattering, optical scatter. There is a forward scatter and there is a side scatter. And if there is fluorescence used, then there will be a fluorescence also. So these are detected, and this optical stimulation is then converted into digital and electronic system and updated into our analyzers. The same thing, we have photodetectors to detect the side and forward scatters. So the side scatter correlates to the degree of internal complexity, the granules and the nucleus, and the forward angle light scatter correlates to the cell size and volume. So by these two, we get to differentiate the different cells accordingly. So the chances of error are recirculation error, where the cells are recirculate through an edge of electrical field. There could be coincidence error, like the cells that pass through the aperture simultaneously, or non-central flow. Sometimes the cells can pass through the aperture but off-center, producing an aberrant impulses, making the cells appear larger than their actual size. So to mitigate this, we can have the hydrodynamic focusing and laminar flow. Coming to hemoglobin estimation, so the blood is mixed with lysing agent, as we all know, to lyse the RBCs and release the hemoglobin. That is treated with either cyanide or sodium lauryl sulfate to get the hemoglobin estimation by cyanamide method or sulfamide hemoglobin method. Histogram is a very important part of autoanalyzers. So in the x-axis, we have the cell size in femtoliters, and in the y-axis, we have the frequency of occurrences. Coming to some common abnormalities that we see in the RBC histograms. So the abnormal height in the lower discriminator can be because of giant platelets, microerythrocytes. Similarly, on the abnormal height in the upper discriminators may be due to cold agglutinins or RBC agglutination rouleau formation. Sometimes we see a multiple peak in RBC histograms that can be because of a blood transfusion, iron deficiency under recovery by therapy. Coming to some abnormalities in the platelet histograms, the most common that we see, and we will be seeing sometime soon in last coming 2-3 months, will be the upper discriminator. So there will be platelet clumps, giant platelets, microerythrocytes, and also sometimes we will see the multiple peaks like the platelet anisocytosis and recovery after chemotherapy or platelet aggregation. So the WBC histogram is what we see after the lysing reaction, where there is a change of size. So here we see the abnormalities, common abnormalities like neutrophilia, where there is a peak in the neutrophil region. Similarly, lymphocytosis, eosinophilia, or monocytosis. Another thing is important for WBC is the scattergram. The upper one is a normal scattergram, where there is normal location of the cells. Below we see the probable locations for the abnormal cells like atypical lymphocytes, blasts, immature granulocytes, monocytes, abnormal lymphoblasts, NRBCs. Some advances in the autoanalyzers are now nucleated RBCs. So we get the reticulocyte NRBCs now in these newer analyzers. We can also calculate the reticulated hemoglobin equivalent, which can be used to monitor erythropoiesis. We get the quantitative immature granulocyte counts. A very important parameters is the important platelet fraction and the platelet large cell ratios. Also, we get the malaria parasites, basophil channel, and cellular hemoglobin concentration mean, which gives a true estimate of hypochromia in iron deficiency anemia. Also, counting cells from body fluids. So this is a scattergram where you can see the parasitized RBCs in this abnormal MP positive slide. Other advances like cytochemical staining, it helps to identify enzymatic nature of differential cells, confirmation of abnormal cells, and no false elevation of basophils. Coming to flags in autoanalyzers, the flags are signals that occur when the abnormal result is detected by the automated blood analyzers. They give the asterisks beside the reports, and this can reduce the false positive or false negative results by instructing the lab tech and the doctor to see the blood smear. So there can be multiple flags in a 3-part analyzers like R1, which can be a lympholeak, R2 can be a atypical lymphocyte, like PM can be a giant platelet or a platelet clot. And similarly, there will be huge number of flags in a 5-part analyzers like leukocytosis, hypolieukocytosis, neutropenia, lymphopenia. It can be left shift, it can be immature cells, it can be bimodality, chyle, hypochromia. So these all gives us the lab tech and us to please go and stain the slides, look under the microscope and correlate with the clinical history. So ultimately it's a collaboration of automation and manual in cases where there is an overlap. So in platelet also there can be flags of thrombocytopenia or thrombocytosis similarly. So take home message is the newer parameters are upcoming, many newer parameters are coming day by day. There is increasing sensitivity and precision. Some parameters like red hemoglobin, they do not have any other compatible manual method, so making such parameters invaluable. Immature platelet fraction gives a very good insight into the pathogenesis of thrombocytopenia and can help us avoid unnecessary bone marrow examination and platelet transfusions. Newer parameters add a lot of extra information to standard CBC, which may translate into better patient care. And ultimately, as newer novel parameters still keep on coming, we need to standardize them across instruments and across labs and use our due diligence how to apply in day-to-day clinical practice. Thank you.
Thank you, Dr. Utso. So since it's a sponsored talk, so we wouldn't have any questions.
There's no question, just wanted to ask all the pathologists who are here, when is the cutoff to do a manual platelet count? Supposing we get a normal reading, say it is 2,25,000. Do we still count in case we see, like we feel there is, the platelet is on the higher side, when it's much more than 2,25,000, when we see the slide? If in the machine it is coming 2,25,000, for example, and when we see the slide, we feel that it is much more, So, should we do a manual count and give that reading, or should we give the machine reading? It's for everybody. I mean, this question is for everybody.
Line of 30 femtoliter or something like that. Nowadays, cell counters have a variable differentiation between RBC size and platelet size. If there is a graph is coming down smoothly, we can trust the machine count. And if the graph is going towards infinity, then the platelet count should be higher.
Thank you.
Thank you.
Dr. Utso. Can we please request Dr. Pollash sir to felicitate? Applause, please. Sir, ma'am, please wait. We would like to felicitate. Please, 1 minute. Huh. Thank you, Dr. Kanoria. And thank you, Pollash sirs, for always being the figurehead of CAP. Please, a big round of applause. Since we are already running slightly behind schedule, we will not be going in for tea break now. For the people who are interested to sip on a cup of tea, please, you're welcome to take a cup from the back. In the meantime, we will proceed with the session 8. For this session, we welcome Dr. Jyoti Chaudhary and Dr. Poonam Kapoor to please grace the stage as chairpersons. Please, ma'ams. Hello. In this session, the first talk is Diagnosis of Rheumatoid Arthritis by Dr. Indranil Chakraborty. Please welcoming Dr. Chakraborty on stage.
Thank you. Very good afternoon and happy Guru Purnima to all. At the outside, I must thank the organizers for giving me this opportunity to present here in front of this distinguished gathering. So today the topic of my discussion is diagnosis of rheumatoid arthritis. So it should be pretty simple. So let's start with, do you have a pointer? The slides are not moving. Okay, so let's start with a case scenario. So 45-year-old female office worker presents to the OPD clinic with pain, swelling, and stiffness in her hands and wrists for the past 9 months. The symptoms are worse in the morning and they improve as the day progresses. There is a history of mild hypertension, which is well managed with medication. There is no history of autoimmune disease and no history of rheumatoid arthritis in her parents. So the physical examination shows swelling and tenderness in the metacarpophalangeal and proximal interphalangeal joints bilaterally. 14 small joints are affected. The patient has a reduced grip strength, no deformity is present, and there is a mild fever. So what is important here is the bilateral and symmetrical affection of the small joints. So if we look at these two X-rays, the one at the left, here you can see the soft tissue swellings at the proximal interphalangeal joints and the metacarpophalangeal joints. Osteopenia is demonstrated by a generalized thinning of the bone cortices. In the later stage, what we can see is there is no gap in between these joints. So ideally, we refer to joint gaps as the hyaline cartilage, which do not come up on the X-ray. So here we see there is no gap, and on the sides of these bones, we can see bony erosions. So what are these bone erosions? Bone erosions are seen at the sides of the bones, which is inside the capsule, but which is not covered by the hyaline cartilage. And another finding that you can appreciate there is periarticular osteopenia. And you can see there is reduction of joint spaces between all these bones. Lab investigations were ordered. A rheumatoid factor was more than twice the normal range, and so was the anti-CCP. C-reactive protein and ESR were all raised. So the diagnosis is pretty simple, that is rheumatoid arthritis. So in 2010, the ACR and Euler classification criteria of rheumatoid arthritis was published, which was basically a modification of the 1987 criteria. So here you can see we have 4 major criteria. Number 1 is the number and size of involved joints. So if one large joint is affected, the point is 0. If 2 to 10 large joints are affected, the point is 1. In 1 to 3 small joints are affected, which includes the joints mentioned, it carries 2 points. If 4 to 10 small joints are affected, it carries 3 points. And if more than 10 joints are affected, which must include 1 small joint, the point is 5. Next is the symptom duration. So the symptom duration as reported by the patient, if it is less than 6 weeks, it does not carry any point. If it is more than equal to 6 weeks, it carries 1 point. So what is important here is for rheumatoid arthritis, we do not use a diagnostic criteria. What we use is the classification criteria. Okay, so diagnostic criteria is usually much broad, but classification criteria, it is more objective with good sensitivity and specificity, and often these diseases are evolving. So we use a classification criteria rather than the diagnostic criteria. The third criteria is the serological testing for rheumatoid factor or anti-CCP, which can be negative. If it is low positive, it carries 2 points. If it is high positive, it carries 3 points. Acute phase reactants are also measured. It includes ESR and C-reactive protein. So if we have a normal CRP or normal ESR, it doesn't carry any point. If we have increased CRP or increased ESR or both, it carries 1 point. So if the total score is more than equal to 6, is the classification of definite rheumatoid arthritis. So the present case has a 3 plus 1 plus 3 plus 1 is 8. So it carries a score that is 8. So it is a definite case of rheumatoid arthritis. So what is rheumatoid arthritis? It is a chronic disease. It is a self-perpetuating disease. It is an autoimmune disease which causes progressive, symmetric, non-suppurative, proliferative inflammation of the synovium as well as the tendons of multiple joints, resulting in cartilage destruction, bone erosion, and disability in the form of joint subluxation, ankylosis, or deformities. It is the commonest form of inflammatory polyarthritis with a population prevalence of up to 1%.
So initially only a few joints are affected, but in later stages many joints are involved and even extra articular symptoms can appear. Women, just like all other autoimmune diseases, are affected more than the men. So most commonly these rheumatoid arthritis, they appear insidiously. The symptoms appear insidiously. Gradually they become more persistent and more joints are involved, resulting in polyarticular involvement. So we use the term polyarticular when 5 or more joints are involved. Rarely there can be acute explosive polyarticular onset, in which the symptoms arise overnight or within a course of few days. They can also present in a palindromic fashion, in which transient symptoms appear in few joints, then they go off, again they come back in the same joints or in different joints. And in palindromic presentation, usually we get those RF as well as the anti-CCP positive. In more elderly patients, rheumatoid arthritis may also present as a steroid-responsive polymyalgia rheumatica involving the shoulders and hips. So these are the various deformities that we usually talk about, the boutonniere deformity, the swan neck deformity, ulnar deviation. In the legs, we have the hallux valgus, the claw toe, the hammered toe, mallet toe, flat foot, Z-shaped thumb, and we may have these joint subluxation or joint ankylosis. Rheumatoid nodules may appear over the prominences, particularly around the elbows and in the hands. So if we take a biopsy, we usually get an area of central fibrinoid necrosis with fibrin aggregates and palisading epithelioid histiocytes. So the differential diagnosis of polyarthritis is potentially broad. Psoriatic arthritis, erosive osteoarthritis, polyarthritis associated with other connective tissue diseases like SLE and primary Sjogren's syndrome, polyarthritis due to infectious agents, reactive arthritis associated with infection from the GU or GI tract or from the upper airway, polyarticular chronic pyrophosphate arthropathy. So all these are to be considered for differential diagnosis of polyarticular affection of hands and feet. So if we consider this picture, you can see in erosive osteoarthritis, of course osteoarthritis, they affect the weight-bearing joints like hips, ankles, and knees. But in erosive osteoarthritis, the small joints can also be affected. But here you can see the affection is usually in the proximal and distal interphalangeal joints. While in rheumatoid arthritis, we have affection of the proximal interphalangeal joints, the metacarpophalangeal joints, and there is a relative sparing of the distal interphalangeal joints. Psoriatic arthritis, again, they appear similar to the erosive arthritis, and pyrophosphate arthropathy and gout, they also usually affect the metacarpophalangeal joints. Extraarticular lesions are also common in rheumatoid arthritis, may involve the skin, the lungs, the heart, the blood vessels. Often few cases of rheumatoid arthritis, they first present with interstitial lung disease or bronchiectasis. Clinical manifestations that overlap with other autoimmune diseases, including SLE and systemic sclerosis. And you should always remember there is no laboratory test which is pathognomonic for rheumatoid arthritis. So this is a very busy slide of the pathogenesis of rheumatoid arthritis. What we should remember is there is a susceptibility, genetic susceptibility. There are environmental factors which results in the citrullinations of self-proteins. This citrulination results in the proteins which are very liable to degradation, and they stimulate production of autoimmune T cells as well as B cells. And here you can see these autoreactive plasma cells, they are producing these rheumatoid factors and these anti-citrulinated protein antibodies. So we use these DMRDs which target either this inflammation or the various markers of inflammation like TNF-alpha, TNF receptor inhibitors. So rheumatoid factor, what is rheumatoid factor? It is basically IgM antibodies against the Fc portion of the immunoglobulin G. So they forms the immune complexes resulting in complement activation and inflammation, ultimately resulting in damage to synovium, cartilage and bone. The sensitivity is high, but there is lack of specificity. It can be positive in Sjogren's syndrome, chronic infections, cancer, or even healthy people. It can be used for monitoring as well. The Anti-citrullinated protein antibody or the anti-CCP antibodies, these target the proteins which have undergone citrullination. So the biological range, this is the biological range. When it is less than 20, we usually call them negative. The key points include the sensitivity. You can see the sensitivity is comparable with RF, but the specificity is very high. And it has got a prognostic value. That is, if the ACPAs are present, the patient usually present with more erosive or aggressive disease. The acute phase reactants that are used are the CRP and the ESR. They are non-specific, but they are useful, and they correlate with the disease activity, and they help in monitoring the treatment response. Other hematologic tests like CBC, neutrophil lymphocyte ratio, platelet neutrophil ratio, mean platelet volume, they again are not specific, but it is good to have a baseline level so that we can monitor the patient, how the patient is responding to treatment. So we use various disease activity scores which utilizes these ESR and CRP. So we can calculate this disease activity score, that is DAS 28, with the help of counting the tender joints, the swollen joints, and